on Philadelphia chromosome-positive ALL, and my topic specifically is transplant or no transplant. And the genesis of this comes from the fact that historically Ph-positive ALL was considered one of the most high-risk ALLs. It's not so much because we couldn't get people into remission with chemotherapy. We could, but the disease always recurred. And so patients wound up dying of the disease when it recurred, with the one possible ability to get them a cure, which was allogeneic stem cell transplant. Of course, in those days, allogeneic stem cell transplant was very much limited by age because the risk of dying from the transplant was so great in older people, so often younger than 50 or younger than 55. The irony of that is that the incidence of Ph-positive ALL increases with each decade. So by definition, most patients weren't able to get to transplant, but those that were did have a possibility for cure, but that left the vast majority who didn't. What has completely changed this, and what's also changed the outcomes for patients with CML, are the tyrosine kinase inhibitors targeting the Philadelphia chromosome. So the first one that was commercially available was Imatinib or Gleevec. We now have several others. Another one that's commonly used is Dasatinib or Sprycel. There's more approved in CML than in ALL, but it's the same concept. They've completely revolutionized the outcomes of these diseases. So what we find now is that not only can we get people into remission, but we can often get them to a real minimum residual disease state where we can't even detect at, say, a 1 to 10,000 cell level the Philadelphia chromosome. And the real question is, now that we're doing so much better with the treatment, does everybody really need to go for a stem cell transplant? Because there are toxicities associated with the transplant, and there's also a risk of dying from complications of the chemotherapy or from the development of graft versus host disease, where the graft, kind of turns on the recipient and attacks their organs. So this is an important question, and in my presentation I make the point that, well, there are no randomized trials, and so all we can do is sort of look at the published trials and try and find patients who didn't go for stem cell transplant, who had good outcomes. And oftentimes those are the people who had an autologous stem cell transplant, meaning their own stem cells were put back in. And that just enables you to give them high-dose chemo. But in older patients, sometimes there are long-term survivals in patients who all they got was TKI maintenance rather than any stem cell transplant. So I'm examining the data, and then at the end I'm going to discuss, very importantly, a new planned intergroup trial in the United States with all the large cooperative groups who are going to get together to answer this question in a randomized trial fashion, where after some sort of therapy, patients with Ph-positive ALL who have a good molecular response will be randomized to just continue on TKI oral therapy or to go for an allogeneic stem cell transplant. And that should really give an answer to the question.